In the ever-changing world of healthcare, are you looking to get advice and learn to prepare for healthcare challenges that you may face? Come join a conversation about all things healthcare and wellness with your host, Gavin Wiswell and Dr. Monsi Shaw.
Welcome to the Healthcare Corner, everyone. And today is an incredibly exciting episode because not only do we have Dr. Ryan Cole with us today to talk about proactive care and understanding different cases with COVID and other diseases, but also because this is our first show that we're doing live on air and video. So, Dr. Cole, it's an honor to have you with us today, and thank you for being a part of the Healthcare Corner.
Happy to be here with you. Thank you.
So, for our guests that are just tuning in, as you know, you can always go to hcshow.net to find old episodes that we have on wherever you get your podcasts, but we will be starting to stream on YouTube and Rumble and anywhere that you'd like to get video content as well. So we're excited for that. And we would like to introduce Dr. Cole to you. He is the CEO and medical director of Cole Diagnostics and serves clinicians throughout Idaho and the nation with expert pathology diagnoses and patient-centered care. So Dr. Cole completed his residency in anatomic and clinical pathology at the Mayo Clinic, and has over the pandemic seen perform and diagnose over 150,000 COVID tests during that time, and diagnosed over 500,000 patients in his career. So, Dr. Cole, I know you also are a family man and have 6 daughters, and we're grateful to have you on the show today.
Oh, thank you so much. Yeah, 6 daughters. That's probably the most important out of all those credentials there, being a dad of 6 daughters. They're good kids.
Yeah, I absolutely agree. As a father of 4, that's incredibly important that you've been able to balance that work life and be able to help so many and be able to raise such a large, wonderful family. So thank you for being with us on the show. And what got you into medicine in the first place, doctor, in this path of life that you've chosen?
I was originally going to be a fighter pilot. I went to the Air Force Academy. I was an aeronautical engineer, and I did some mission work in Argentina. And when I got back, I decided I wanted to heal people and not drop bombs on people. So my grandma one day sitting at the kitchen table, she said, you have the hands of a doctor. You should be a surgeon. So I thought, that's too many years of school. But I kind of followed that path, and I thought, okay, let's give it a go. And I did well on my MCAT and admissions tests, and I'll be darned if I didn't get into a bunch of med schools. So it wasn't, from the time I was in a sandbox playing as a kid thinking, gosh, someday I want to be a doctor. In fact, I was on runway approach to Andrews Air Force Base, and I watched those fighter jets during the Vietnam era come landing over my head every day, and I thought I wanted to be a fighter pilot. So the path chose me. I didn't choose it.
Wow. No, thanks for sharing that. My brother, he was kind of out of the gates, knew exactly what he wanted to be. And he wanted to be an orthopedic surgeon, but then things changed and he became an oral maxillofacial surgeon instead and kind of found his path there. So when it comes to pathology, was that something that you got into med school and then realized that, gosh, this is a passion of mine? Or?
It was something that called me. I thought I would be a rural family doctor. I was president of our family practice association. And then when I got into my path courses in med school class and I had some mentoring, you have an eye for this that we usually don't see. I'm a very visual learner. And so just looking at patterns, it kind of selected me and found out where my strengths were.
I appreciate you sharing that. And I think that through this pandemic, and the topic of the show today is really, I think, understanding COVID and infectious disease. And what we want to really accomplish is the navigation of that. I mean, really the country, and I think the world, has been put into now a new way that we're addressing just infectious disease and communicable diseases as a whole. And the purpose of the Healthcare Corner has always been to improve our listeners' healthcare education and to really be proactive with what they know. And I think you so eloquently put it on your website, where Dr. Cole can be found is rcolemd.com. And you talk about prevention, testing, early treatment, hospitalization with COVID, and then long haul COVID-19. I think that's really a more recent event that we're seeing where they're just kind of longer effects. And as the data is starting to come out, different studies that are out there that reveal that some of those that have been vaccinated maybe even have more proclivity to getting the disease. So these are all topics that I think we want to get to on the short hour we have here on the Healthcare Corner. And I think let's go ahead and get started. So when it came to COVID-19, can you kind of start with that journey of your introduction there? I know that for us, because of our background in healthcare, we were asked to go into some of the first buildings in skilled nursing and identify this new disease. But when did the pandemic really come to your front door, and how did you approach your entry into dealing with the pandemic and that disease?
Well, similarly to you guys, ramping up testing right away. We knew from the announcements that there was a virus circulating and the pandemic was announced out of China. And I, with my background in virology, clinical pathology boards, and I did some PhD work in immunology as well, I had studied SARS-CoV-1, I had studied MERS, I was very familiar with the family of coronaviruses that we're dealing with. So first things first, it was like, well, how do we test for it? How do we see who has it? And so we did everything we could to get high volume testing up and ready for the community, which, as you know, most people know, was a challenge from the get-go because most of the supplies and testing materials went to the large corporate lab. So getting it at community level was a challenge, but we took that challenge on, and as soon as we could, we set up a testing facility in our parking lot and precautions and whatnot, understand what was coming. And also took that opportunity because we had so much face-to-face interaction with the community to educate and to calm people, because I think going into this, there was a lot of fear and anxiety, and it was important to us to help people understand, okay, how can you be in your best health to not be a victim of this disease, and what could you do to be able to basically put yourself in the best health status, because again, a pretty quickly spreading virus, and a lot of people were afraid and concerned. I knew going into it, based on the studies of SARS-CoV-1, it was unfortunately mainly a disease of the elderly, and as you saw in your facilities, I'm sure, it did have a propensity to hit that older age cohort, and that was sad, because we did see a lot of poor outcomes in parts of the country, and there are things obviously we could have done in retrospect, but even with foresight at the time, there were things that I was preaching that I knew would help, and thankfully some groups took those on and others unfortunately didn't. For example, vitamin D levels. We know we have a vitamin D deficiency pandemic internationally. Because of our Western lifestyle, we spend too much time indoors. We're not out in the sunlight. We're not optimizing our immune health. I like to call vitamin D the master conductor of your immune system. And if it's at a good level, even the Mayo Clinic did a study, where I trained. They said, look, if your D level was above 30, you didn't go to the ICU, and basically you didn't get intubated. And so it's things as simple as optimizing vitamin D levels. I worked with several nursing homes as well, and skilled nursing facilities. And that was one thing I helped a lot of these directors understand, is this older population that you have indoors. 82 to 88% of them are vitamin D deficient. And if you can just optimize that alone, you can markedly decrease the risk factors for those individuals. And then now that we're 2 years into this, 2+ years, we can look at several large cohort studies from around the world that confirm that very finding.
Excellent. And it's one of those things I think as well that we wanted to address some of the data and understand maybe some of those key points that maybe weren't addressed beforehand. So when you're talking about vitamin D, I know that just in general that's a very important thing, but when we're talking about the SARS-19 itself, sunlight and exposure to sunlight, didn't that kill that
that's a great
as well
point.
too? So it's kind of a double-edged sword in a good way, right?
So it's interesting. We took all these interventions and measures, but it's still, I think, kind of sad when you're outside and see somebody walking outside with a mask on or riding a bicycle, because sunlight is a wonderful disinfectant, and the sunlight, and there are several studies from around the world that confirm what you just stated, and that sunlight fractionates and breaks apart this virus. So, and the other thing too is outdoors you have nice air circulation. That was one of the biggest problems we had early on in New York. As we locked down, we did just the opposite perhaps of what we should have done, and that was we put people in closed environments with poor ventilation. And if you're outdoors, that sunshine kills the virus, and there's not enough concentrated virus really to infect in outdoor groups. So great point. Yeah, the virus is affected by sunlight, and that's why even like UV light in indoor settings, filters with UV lights on them can kill the virus. There's newer UV bulbs that can be used with people in the room now, and UV lights that can be put in vents and cleaning systems that are very antimicrobial. And so things as simple as that are very preventative, not just for this virus, but for other infectious agents in any indoor environment. So ventilation is important, UV light is important, and then being outside for your health is critically important. We just as a society don't get outside enough. Not only do you get vitamin D synthesized in your skin through sunshine, but you get near infrared light, which is really good for producing subcellular levels of melatonin, which is a great antioxidant, not the sleep kind, but the cellular kind. So being outdoors in the sunshine, I think, is just something we've drifted away from societally over many years.
No, thank you for sharing that. And in San Diego, we get our sun down here for sure, but in other parts of the country, it's not that way. And even in San Diego, unfortunately, I think a lot of our youth still stay inside too much and need to have that balance. And so, as we're wrapping up this first segment of the show, I think what we also want to address on the show is really some of those other treatment options that are out there. We want to be able to talk about the difference between the importance of testing and the vaccination and the different types of vaccines that are out there that really, I think, caused a lot of concern amongst individuals. And then the importance of just other diseases and the precedent, I think, that COVID has set. So as we continue with Dr. Cole, please stay tuned. And I hope you're enjoying our first new video episode here on the Healthcare Corner. So stay with us.
To learn more about being a guest on the show or to ask a host a question, go to hcshow.net or email the show at info@hcshow.net to get your questions answered on the Healthcare Corner. Don't go anywhere. You're listening to the Healthcare Corner with Gavin Wiswell and Dr. Mansi Shah. Welcome back to Healthcare Corner, where you're a part of the conversation with your host, Gavin Wiswell and Dr. Mansi Shah.
Welcome back to the Healthcare Corner, everyone. And today's episode with Dr. Cole is more about the academics and the data behind COVID-19, what we've learned, and really what we can do not only just for what our lives and dealing with COVID will be in the future. I don't think it's going anywhere anytime soon. I think it's going to be maybe more like the flu, where we're going to see, come up maybe every year, or doctor will correct me on that, but really understanding the how do I say this, doctor, the effects of what we've learned over these last 2 years and what we can learn to improve from it and be more proactive.
Yeah, absolutely. And I think one of the main lessons we learned in retrospect is we have medications and treatments that we can look at that historically are safe. And many of those medications we knew historically with SARS-CoV-1 were actually inhibitory of SARS viruses. And unfortunately, some of those medications got suppressed, and we knew that they were effective. And in retrospect, there are large data sets. If you go to c19study.org or .com, there are data sets breaking down about every treatment and the percentage efficacy thereof. I think c19meta.com also has that data. So a lot of treatments that obviously became unpopular in the mainstream media, unfortunately, could have been used early. And even if you take away a lot of the drugs that shall not be named, the other important thing is we knew early on that COVID was a clotting disease and an inflammatory disease. So at the first phase, you have the sore throat stuff. You knows replication phase. But about day 7, 8, 9, 10 was when we started seeing the extreme cytokine storm and things of that sort. Well, we had approved medications on the market for that as well. Interestingly, something as simple as aspirin could have prevented a lot of the clotting conditions. And then just tuning down inflammation when one is in a hyperinflamed state. And it took a long time societally just to get steroids accepted, just to tune down inflammation. So the sooner we could get patients treated, the better they did. And another very simple thing, Dr. Chetty out of South Africa had a huge cohort of patients that generally came to him later, at the end of that first week. And using anti-clotting agents, steroids, and antihistamines, he was able to do incredibly well statistically with his patient cohort. And then the other thing we did that, and again, I'm not here to judge if someone got a shot or didn't get a shot. People were afraid. They did what they thought was going to be best based on what they knew at the time. Going into this, coronaviruses generally aren't amenable to vaccination, and that's because they mutate too quickly. So when we said we were going to have Operation Warp Speed, I had my medical concerns in the sense that by the time you have something formulated, you're on to the next variant, which we saw happen worldwide, variant. And there was the hope that what we did would cover whatever was coming next. But if we look at the SARS-CoV-1 trials and the MERS trials, there was a reason we were never able to vaccinate against those coronaviruses because of the mutation rates. And then when we did vaccinate and the animals in those trials were exposed to another mutated variant, they actually tended to have more inflammation and poorer outcomes. So that's an immunologic concern I had going into this. And here we are. So we have, two types of shots that were brought out to the society. And these aren't normal vaccines. Normal vaccines, you take a killed protein or a killed pathogen, and you put an immune stimulant in with that, and then you inject it, and the body recognizes that. This is a completely new modality, and that's taking a sequence of a gene that makes the spike protein for the virus, shielding it in a lipid nanoparticle, and then injecting that. So that's technically a gene product. So the FDA authorized these. They used standard vaccine criteria, and they should have used gene-based criteria, looking at biodistribution, genotoxicity, reproductive toxicity, dose-based toxicities, et cetera. They didn't do that, which was unfortunate. And that's why we've seen, I think, a fair amount of injury from this. If you look at the VAERS data, which is a very underreported system, but it's the best system we have, but it does match the data reporting systems, the Eurovigilance data system in Europe, as well as the yellow card system in the UK. So we used a new modality that was experimental.
And so for some of our listeners that are less scientific, what you're talking about is traditional vaccines are more like polio or smallpox or something along those lines. And because COVID just mutates so quickly, you're now looking at gene therapy. And so there should have maybe been different protocols or a set of standards to use, or maybe even just a different modifier. Like we maybe shouldn't have called it a vaccine as much as it is a booster shot or something else that maybe could have defined it better.
Yeah, it was more of a biologic therapy attempt, and
gotcha.
Because really in the criteria in the trials, their end criteria wasn't to prevent disease. It wasn't to prevent acquisition of disease or transmission of disease. Their criteria was, did it decrease symptoms? So their endpoint was very simple. And maybe at first, for a hot minute, it did that. But once the other variants came along, it didn't. And now we're to a point where those, and this is large data set out of Walgreens. Walgreens released their data on several 100,000 patients and shows now that if you receive 2 or 3 of these shots, you're actually, because of some of the immune suppression that's been caused, you're acquiring Omicron at far higher rates than the general population. And the other, I think, important thing that, we get this unfortunate argument in society, vaccinated, unvaccinated. Really, the important thing to consider is how many people are COVID recovered, how many people have immunity now to the disease or degree of protection because their immune system was trained by being sick with the virus. And if you've had a disease, and Anthony Fauci said this in 2018 about influenza shots, he said, look, if you've had a disease, you don't need a vaccine for the disease you've had, because having the disease is the best immunization of all. And so, I mean, that was Fauci, and people like him or not, plain and simple, that's true. Once you've had a disease, if you've had COVID and they get a shot on top of it, papers by Dr. Rao, Dr. Kammer, Dr. Mathudia show that you're at a 2 to 4-fold increased risk of adverse reactions, because your immune system's already done, what it was designed to do, and that's to fight off the virus, recover, and then provide a broad, natural, full immunity to the whole virus. This is the other challenge with the shots, is the shots are targeted just to the spike. So they make your body make the spike. Now, studies at the Salk Institute there in Southern California outside of San Diego showed that the spike protein itself is the toxigenic aspect of this virus. So we literally made a sequence and a shot that makes your cell make the toxic part of the virus, unfortunately. So in retrospect, it wasn't well chosen. We could have picked other parts of the virus that would have been less pathogenic. And so because we used that spike, now the body making that spike can induce some of the same changes, inflammation in the lungs, the brain, the heart, the liver, etc. And we saw that after the rollout of these shots, is because we chose the toxigenic aspect of the virus. And it caused problems. But the same thing, the spike is only about 12% of the virus. So when you get a shot, you're only recognizing a small portion of the whole. Whereas if you get a natural infection, you recover. Now you have memory to 100%. And that's why these shots, the viruses escape the shots. And it was predictable looking at the history of injection attempts against coronaviruses in this family.
And was there one shot that was better than the other? So say the 2-step or the 1-step, were they different enough, or did it not really matter which shot you took?
Well, it didn't really matter if you retrospectively look at the data. And unfortunately, Pfizer, for example, in their trials, we saw in the injection group, in the Canadian COVID Care Alliance has a really good presentation on this, there was more bad outcome in the shot group than in the placebo group. So the all-cause mortality was higher in the shot group. Moderna is a higher dose and actually tends to have more reactions. You don't tend to hear about that in the news as much. Then the J&J, and in Europe they used AstraZeneca, they use an adenovirus, but from a chimpanzee, and then they inactivate the virus and then put a sequence of DNA in that makes your cell make RNA and then make the spike. All of them, the shots tend to make more spike than a natural infection does. And that excess amount, be it the J&J adenovirus vector or be it one of these mRNA shots, none of them were a traditional shot. And so they all had, some of these unfortunate outcomes, some of which were predictable medically based on the trials of this type of technology, which has never been used broadly on humanity before. Moderna was 0 for 8 bringing products to market because they always had problems in their animal trials. The CEO of Pfizer, Bourla, said in a meeting to his scientists, look, why are we using an mRNA technology instead of a traditional vaccine? Because we've only been working on this technology for 2 years. So it was fascinating that this type of technology was used experimentally on humanity without knowing, and we still don't know the long-term outcomes. It usually takes 5, 10 plus years to bring a shot vaccine safely to market, because then you have all the trial data for many years for long-term outcomes. And we still don't know with this. We can predict certain things immunologically that are concerning, but we just don't know. And you can't advance that clock or look into the crystal ball and know.
And I think that brings up a good point, probably for our next segment. But it sounds like if there's cell mutation, right, and we don't really understand what's going on, and we've now put this into our children and our loved ones and our seniors, gosh, there's a lot we're going to learn over the next 5 to 10 years. So just as a teaser, Doctor, for our next segment, do you feel like this is going to be like the flu in a sense that every year that there might be SARS COVID-19 and another strain or something that we're going to have to, adapt to every year, kind of like the flu ongoing? Or
we will see it every year as at a buzz level, endemic level, because so many people have been infected. We can get into that in the next segment, but yeah, we'll see it as it will be in society forever now. Yes.
Excellent. Well, I hope you have out your pen and paper and you're taking notes here with what Dr. Cole's sharing with us. So stick with us here on the Healthcare Corner as we continue.
To learn more about being a guest on the show or to ask a host a question, go to hcshow.net or email the show at info@hcshow.net to get your questions answered on the Healthcare Corner. Don't go anywhere. You're listening to the Healthcare Corner with Gavin Wiswell and Dr. Mansi Shah. Welcome back to Healthcare Corner, where you're a part of the conversation with your host, Gavin Wiswell and Dr. Mansi Shah.
Welcome back to the Healthcare Corner, everyone, and hope everyone's enjoying our new live stream that we have here with Dr. Ryan Cole. And we're talking a lot about COVID and the history of it and the vaccine. And Doctor, what I heard a lot of the people that reached out to me that I knew personally or professionally, they thought of the COVID strain and the vaccine very similar to what you would find with a regular flu vaccine, and how each year, my understanding is that with the flu vaccine, we have an opportunity to kind of see what it's going to be. And by the time it says reach our area, we've got a decent chance on putting out a vaccination, I should say, that would help us to lessen the effects of the flu. But COVID doesn't really act like that. Am I right in saying that?
Yeah, they're different families of viruses. You're correct. And so flu does what we call a recombination. So you hear H1N1 or H2N5. So it has these different hemagglutinins and neuraminidase, and it recombines usually between pigs and ducks and people in generally farm settings and whatnot. So they'll track it in Asia and in the Middle East, and then they'll try to predict what are the most common strains and pick those three predictively, trying to formulate what they're going to put in that next season's flu shot. Now, unfortunately, this year, the flu shot was only about 16% efficacious. So they misjudged
1/6,
it.
right? Not 60?
1/6. No, 1/6. Oh. Yeah, 16. So in the teens. So they mispredicted. Now with coronaviruses, they don't recombine like that. They have sequence mutations, substitution or deletion. So you're not getting whole parts of virus recombining with each other. So it's more of a mutational drift is what we call it. So that spike protein, you keep hearing, okay, now we have the alpha, now we have the delta, parts of the world got lambda and mu, and other parts had gamma. And that's because of these little mutations that are happening mostly in the spike. That's where most of the mutations happen. So it's hard to predict what's going to mutate next within this spike of the coronavirus. So it's very difficult to predictively try to guess. We know that now that the virus is here, it's always going to just slowly mutate. We're lucky in the sense that Omicron is more of a common cold for the majority of people. And that's good news. So I jokingly call it coldvid, not COVID now, because it is more of a cold, and that's great. It lost a lot of the binding where it binds on certain receptors in the body, so it doesn't affect the lungs as badly as the earlier variants did. It still can cause clotting in some individuals, but not to the degree that we were seeing earlier. So in a good sense, it's mutated to where we can live with it, and we can only hope that it stays more benign like it is now and less virulent. Does it spread? Do people get it more quickly and readily? Yeah. But is it a cold in the majority of people now? Yes, as well. And that's good news. So that's an optimistic aspect of it. But it'll be with
Excellent.
us, and it's going to mutate. So go ahead. Sorry. Go ahead, Kevin.
No. So that it's good to hear that it's more mild, and you hear of terms like herd immunity and that sort of thing. And last week on the show, we had a doctor of physical therapy that really focused on, children and youth exercise and proactivity in that respect. And I think of just our children that we have that are, the face shields, and still you see the masks and they're optional, but a lot of kids are scared to death to go maskless now. and just kind of what that does to maybe the respiratory system always having a cover on. So just wondering your thoughts and the research for kids that are playing in schools and just, even with high end sports relative to this long haul COVID that you're starting to hear about that will exist on the long term. So would love to kind of turn the direction of the conversation that way.
Okay. Yeah, as far as the kids go, I mean, it is unfortunate that we're still scaring them. Kids, if you look at Sweden, they have 1.8 million children that got to go to school the entire pandemic. They didn't have a single childhood death. They got to live a normal childhood. Children are really the bridge to immunity for society because they do so well with this virus. Their survival rate is 99.9973%. Kids aren't adversely affected by this. Now, unfortunately, did we lose some children that had severe underlying conditions? Yes, we did. But overall, kids have strong innate immune systems. So when you hear about antibodies, that's your adaptive, but your innate is your T cells, your dendritic cells, your monocytes. Because kids, play in their petri dish of school, their immune system was predisposed. It's interesting. Over a month ago, the CDC data showed 75% of America's kids have already had COVID. And what did we do? I mean, that's 75% of the kids with all these measures of masks and all these measures in schools. That means they got it anyway. They got it anyway. Okay. And they were never vectors spreading it to grandma. It was just the opposite. Adults spread it to children. Kids have fewer of the receptors to bind the virus. They never had high enough viral loads to really be the vectors for the disease. So at this point, really, we need to do a large population immunity study because these kids that have had COVID, they don't need to be afraid wearing a mask. We're psychologically harming them. And in the laboratory, we did culture the masks, and we saw unusual throat infections, sinus infections with bacteria and organisms we usually don't see because of that moist, dirty environment of that mask. And there's not a single study in the world, not one single randomized control trial showing that masks work in a community setting for respiratory viruses, plain and simple. So we want to think we're doing something, but really what we're doing is psychological harm to these children. And I think a lot of that carries down from the degree of fear that a parent may or may not have. But, going back to my earlier point too, kids who have had COVID don't need a shot on top of that. We've seen too much inflammation of the heart in these children, myocarditis. Studies out of Hong Kong showed that with the mRNA shots, 1 in 2,700 kids were getting myocarditis. We saw studies out of Israel showing in the young cohort the large number of cases of myocarditis in young individuals. And then most Scandinavian nations actually banned Moderna, and then Taiwan banned mRNA shots as well because they were seeing too much inflammation in young people. And they have robust immune systems. They were literally the bridge to herd immunity had we let things occur like Sweden did. And, it's not a 2-year-old's job to protect an 80-year-old, but vice versa, an 80-year-old's job to protect a 2-year-old. And certainly, if this were flu, maybe it would have been like a horrible flu season. Kids have a higher propensity to get the flu, and some kids do poorly, but the flu death rates tend to be higher in children, but not with coronaviruses. And so really we took a different approach that wasn't, in retrospect, scientifically accurate.
Well, and when you're looking at high-end athletes and I think males in general, I think I was reading some things that showed that there were a couple of seizures and even some football players, right, that really had the vaccine and then shortly thereafter were now out of their sport, out of their profession because they were forced to take those vaccines. And then I heard of other athletes that were weightlifters and that sort of thing that then had this long haul COVID that really didn't allow them to respirate like they were and to be able to do their sport the way they wanted to because of the vaccine. Was that more of an anomaly, or was that actually more suppressed and there were more cases of that?
Well, there's a lot of cases of that, and part of the challenge is the youth are more active and they perfuse their tissues at a higher rate. So if you put a lipid nanoparticle that can go anywhere in the body, goes to the brain, the bone marrow, the spleen, the liver, et cetera, and the heart, because they're exerting harder, that lipid nanoparticle can get through the little cracks between the cell junctions, and then that spike can replicate anywhere. And so we were seeing a lot more of that post-shot in athletes around the world. I mean, usually you'll see a handful of professional athletes that die every year because some genetic anomaly or whatnot. But with these shots, we're seeing, I mean, thousands of percent increases that we've never seen before. And that's because of that toxigenic aspect of the spike. And so and then long haul, what is long haul disease? It's not the same in everybody. There's a couple of categories. So some have reactivation of some of your allergic cells, your mast cells. So some people have what we call mast cell activation, and that involves maybe eating a lower histamine diet, using some antihistamines to block some of the fatigue caused by that. A very important aspect, and we've seen a lot of this after the shots, and running a laboratory, I've seen a lot of this. A lot of individuals, be they young, teens, 20s, all the way up into their 90s, have reactivated Epstein-Barr virus, mononucleosis. So it would behoove any clinician listening and any patient that's having the severe fatigue after the shots and or after COVID. COVID itself can do this because of how it affects certain cell receptors, but it can reactivate a lot of the different families of viruses that lay dormant in our body. We saw a lot of shingles after the shots. That's a herpes family virus, herpes zoster. We saw a lot of reactivation of mono. A lot of latent dormant viruses and microbes in our body because of some of the immune suppressive effects of this spike protein allowed other things to wake up in the body. So that's one thing for clinicians to always think about. Hey, is there something else that woke up because of the immune suppressive effects of that spike? Be it from the virus itself and or be it from the shots. Either way, it's a spike that's circulating and causing these effects.
Gotcha. And what percentage of folks that have COVID get this long haul COVID? Is it?
You got me there. I think it's single digits. I mean, it depends on the studies you look at. Some people will say, 10%. I've seen others go a little higher. I've seen others go a lot lower, because you really have to consider, are they counting everybody that had COVID? Because a lot of people had COVID and didn't know they had COVID. So it really shifts the percentage as to, the infection rate versus the case rate. We can count so many cases, but only if you are tested, but the actual number of infections in society always tends to be higher than those ones that we actually do detect and test. So that percentage is going to vary according to the study you look at. Unfortunately, it's something that happens and people do need to look out for. And there are treatments. I mean, I've individuals do quite well with therapies and treatments, be it hyperbaric oxygen therapy, ethylene blue, near-infrared light sauna therapy, some of the drugs that shall not be named therapies, because in a lot of human bodies, the challenge is the spike from the vaccines, that's modified RNA in the shot. A study out of Stanford, Dr. Roltgen et al. In the journal Cell shows that the body is still making and spike protein up to 2 months after the shot, and that synthetic mRNA is still present in lymphoid tissue at least 2 months after the shot. And they stopped the study at 2 months so they could publish. It likely goes on longer than that in a set percentage of individuals. So the chronic presence of the spike in these individuals can be causing some of these chronic long-haul symptoms through many different physiologic mechanisms.
Wow. Well, this is incredibly fascinating. We're into this segment here, Dr. Cole, but I think for our listeners out there that want to understand what 3 things we can do moving forward, don't go anywhere. Make sure you're taking notes, and you can always go to hcshow.net and listen to this episode and any other episode that we have. So stay with us here on the Healthcare Corner.
To learn more about being a guest on the show or to ask a host a question, go to hcshow.net or email the show at info@hcshow.net to get your questions answered on the Healthcare Corner. Don't go anywhere. You're listening to the Healthcare Corner with Gavin Wiswell and Dr. Mansi Shah. Welcome back to Healthcare Corner, where you're a part of the conversation with your host, Gavin Wiswell and Dr. Mansi Shah.
Welcome back to our final segment here, the Healthcare Corner. And today's episode is with Dr. Ryan Cole, and we've been talking all things COVID and vaccines, and I sure have been learning a lot. And for all of our listeners that listen each week, you know that this is the segment that we're going to have, that we get 3 really helpful hints that you can put into practice right away. But before we do that, Dr. Cole, really appreciate you coming on the show and informing our guests of all that you know and the science behind what you've learned over these last couple of years. And so, if someone wants to learn more or understand more about the studies that you're referencing, how do they get a hold of you?
I can be reached at rcolemd.com. And you can also find a lot of information at, and you have to type it in, globalcovidsummit.org. So those are 2 places where it's easiest to get information.
Well, thank you so much for sharing that. And so for our listeners and for those of us that have young children and also parents, maybe we could mix it up a little bit in this last segment, Dr. Cole, and maybe have 3 bits of advice for our youth and maybe then for our geriatric population as well too, or maybe it's the same advice for everybody. I don't know, but we'd love to kind of go from there.
Okay, so a very simple one right now, and I know this may sound controversial, but it's science. The shots were made for the original variant that came out, the Wuhan variant. They've never been modified. So when they say go get a booster, we're several variants later. Now we know from world data now, unfortunately, a very simple piece of advice, it's the wrong shot now for the wrong virus. It increases your chance of getting the virus, there's actually more risks technically from the shot now than there is from getting the virus itself. And so, I mean, my first piece of advice, and again, I know it's not going to be popular with some, but hey, this is science. Wrong shot, wrong virus. Don't get another shot. Don't load up your body with more spike protein. So that's one. Now let's get a little more optimistic here. What can you do? I always joke, right now, you're the best doctor you'll ever meet is here at the moment. And people are like, gosh, that sounds arrogant. I'm like, no, it's you. Look, you're the best doctor you'll ever have. You know your body better than anyone else. You know what your healthcare risks are. You know your health history. You know that most people know the things they need to do. Look, if you're capable, move your body more. Exercise showed a marked decrease of hospitalization if people had a history of moving their body. And I'm not saying go to the gym. Go outdoors for a walk. Just move your body. Just having really good blood flow. Not only is it good for you physically, it's good for you mentally to be out in the daylight and the sunshine. It's good for your mood. So do things that are easy to do. Another study that was fascinating, it was an AI algorithm that looked at all the papers written on COVID, and the one factor that popped up above anything and everything else was the word sugar. So goes your blood sugar and your ability to control your blood sugar. So goes your ability, not just for COVID, but for any infection and overall wellness. A lot of us in America are insulin resistant. We eat too much sugar in our diet. If I want to make a lab animal vitamin D deficient, I feed them high fructose corn syrup. What's in 80% of the food on our store shelves? High fructose corn syrup. I'm not saying sweet things don't taste good, but we indulge too much, and that messes up our immune system and our ability to fight off infection. And so simple things, move your body, choose what you do and don't put into your mouth and into your body, because that affects how inflamed you are or aren't going to be going into any infection, not just COVID, going into flu season, going into cold season. The less inflamed your body is, the better you're going to do. We mentioned vitamin D earlier. That's very important in terms of just overall health and wellness. And then the other important thing too, and I think we've lost this, is being in community. Having a community is critical for mental health. We saw so much damage psychologically from this disease. Alcohol abuse, drug overdose deaths were higher than we've ever seen in our nation and around the world as well. So being in community, having a network is good for your mental health. And the better you are in community, the lower your stress level, the more optimized your immune system is in terms of function. So being number 2 risk factor for bad outcomes in COVID behind obesity was stress, fear, and anxiety disorders. And that's because it dysregulates your immune system. So finding that way to have connection and community. Then I think the other important thing too going forward, okay, there's scientists that won't agree with me. There's scientists that do. I'm here to say we need to have dialogue. The one thing we really lost in this 2 years was the inability to communicate. You don't have to agree with me. Wonderful. If you don't, bring me better data than I have on behalf of humanity. And that's what we need to be doing with each other as well. Great. We don't always agree. That's what makes this a great country, is this virus isn't red or blue politically. It's not purple. It's a virus. But at the end of the day, we should be caring for each other and bringing best data forward. And you can't do that when you censor information. When you hide information from people, it means you have something to hide. The plain and simple fact is data and science should be free and open discussion. In the hospitals and grand rounds, doctors always disagree. But at the end of the day, we're still doctors and we're still trying to do the best by the patient. So I really think communication is critical.
Yeah, I think that's a great point. I would much rather go to a doctor that tells me, and it has great conviction, as opposed to a doctor that would say, I don't know. What do you think? Right. It's like one of those old Verizon commercials, like, hey, just passed, right. Or whatever it was, where it shouldn't be by consensus, right? The data should back up completely what you're saying. And if you've got better data, then absolutely bring it. I think back to my days in the nursing home of universal precautions, right? Making sure that we're covering our cough and washing our hands and doing it the right amount of time, and making sure that we're changing our gloves appropriately when we're seeing people, and not taking that into another room and evaluating somebody. So all of those things seem to be common sense, but not common practice. And so
correct. I like how you put that. Yeah. Common sense, but not common practice. And I mean, one of the most simple things we really could have done, and I saw this left and right over the last 2 years. Look, if you're sick, stay home. Don't be a vector of disease, and it's so easy to rationalize. Oh gosh, I just have a sniffle. It must be allergies, this, that, or the other. If you don't know, those individuals that are at high risk, don't put them in an exposed risk. And to your point, really at the end of the day, common sense things that we could have done that really maybe could have given us different outcomes. Yeah. And I think you mentioned a couple of those.
So I think today on the show, we've learned about early treatment and what that was like. We've learned about the vaccine and the differences between what we think of flu shots and the differences there. I think you've brought up some great preventative health choices that we can make so that going forward, when we address a new pandemic, whatever it's called. I mean, I remember in my lifetime, just H1N1, right, is something that you brought up earlier in the show. COVID. You even think about HIV back in the day and what we didn't know then back in the 80s, and now you've got monkeypox that starts to be coming out. So there's always going to be something that comes up, and so I think from your global view, it's important that we not only look at our country, but also that of other countries as well, to be able to pull in better research and data so we can prepare ourselves to protect ourselves and those that we love. Is that fair to say?
Yeah, well stated. I mean, we have science for a reason. We need to follow it, convenient or inconvenient. Disease will always be amongst us. There will always be new diseases. But what can we do from a personal level? Obviously, we can do those things, and we should do those things. And so I think it's very important not to live in fear. It's wonderful there are so many people on this planet, because the human body is an amazing thing. So I think common sense things like you brought up, optimizing health and nutrition, optimizing wellness, optimizing what we do and don't do with our bodies is very, very important. And life is a beautiful thing. Don't live in fear.
Yeah. Doctor, you mentioned how, we used to think, oh, it's just a sniffle, I'm okay, I can go out there. And it feels like it's been completely flipped now, right? Where it's like, oh my gosh, they've got a sniffle, they must have COVID. And I could get it.
Right.
We saw a lot of that. So how do we get balance in the final couple minutes that we have here on the show?
I had to play this game. I have a couple younger kids still in school, and we making testing more available and simpler for home testing. I wave at the fever. And so if you can test for a few things for pennies on the dollar is really what we're shooting for, and have an accurate measurement quickly, then okay, gosh, it is just allergies. It's not this or this. So, in this day and age, I think we are more conscious and conscientious that, oh, okay, I do have some symptoms. Maybe it is. So I think just being careful. I think being courteous and careful is always a good idea. and going ahead and not putting people at risk. I think that's common courtesy.
Yeah, and I think it brings to your point about community, right? And just that understanding that we are better together, that not having the same opinion is an important thing, right? Debate is a great thing as well. And so I noticed even when we'd attend church and see that some people would wear a mask, some people wouldn't. You have a pew in between, and others you wouldn't, and it's so hard to control. But I think that understanding and respecting someone's opinion on their own health and helping them feel comfortable to be around others was I think the overall goal. So I think you've brought a lot of great points to the show today, and we really appreciate all that you've shared here on the show. And Dr. Cole, again, can be reached at rcolemd.com. And really, what I love the quote that you have on your website, that there is a freedom movement out there, right? And that we do need to understand that there is better data to be had, and that science is not done by consensus, or shouldn't be. Is my takeaway from the show. And so, any final thoughts in these final 2 minutes that we have here, Dr. Cole?
No, I appreciate that. Yeah, and thanks for the opportunity of sharing with your listeners. And science isn't done by consensus. And you look historically, people like Galileo, he was right. He was persecuted and thrown in the tower for being right. So sometimes scientific data isn't convenient, but at the same time, I have no ego about it. If I'm wrong, teach me. I think that's how we advance societally, is having an eager curiosity and being teachable and not being so rigid in thought.
Yep. The more we know, I think the more we need to learn, right? So thank you so much, Dr. Cole, for being on
Correct.
the show, and for our listeners. Hope you enjoyed this week's show, and we'll see you next week here on the Healthcare Corner. Have a great weekend.
To learn more about being a guest on the show, or to ask a host a question, go to hcshow.net or email the show at info@hcshow.net to get your questions answered on the Healthcare Corner with Gavin Wiswell and Dr. Monsi